Okay, so we, meaning me and many other people, have tons of this longitudinal PCR data. So this is a really attractive thing for mathematic modelers, right? You can look and see how disease changes over time. And so in various trials of imatinib and nilotinib, people have looked at the slope of disease kinetics, and it looks like this. So these are like the rough, all the individual patients. But every study has found that you get this initial first slope followed by this slower slope. And what the thought is that these are all people who are basically committed progenitor cells, and you wipe them out really fast. And then you've got these stem cells who occasionally cycle, and you slowly block out the reserve, and it goes farther and farther and farther, right? That's what we hope. So from that, you can make these predictions about how long it would be to actually take to eradicate someone of all their CML disease. And so this is by 2 trials, IRIS, and this is the German trial. And so from these models, you say, well, to completely eradicate MRD, it's going to take 30 to 50 years based on how many billions of cells you've got. And the treatment time to get to a 4-log reduction is going to take basically a decade. And then how we estimate number of cure rate after 15 years of therapy is only 15%. After 30 years, only 30 to 40%. And so I said, well, that settles that. You're on tyrosine kinases for life, right? I mean, there's no way anyone's going to get off them. And that was backed up by some interesting biology that was done. This was by Ravi Bhatia, and I'll make this pretty simple. What he took is he took long-term CML patients and took marrow from them and then sorted CD34 primitive cells, as close as you could get. And, it's still somewhat of a religious belief whether or not they're leukemia stem cells or not, but you take what you think of them, and then you grow these various populations, and then look and say, and darn if all of them don't produce B-cerebral signal. These are people who have been on and who are by conventional PCR are negative, but when you enrich for the CD34 cells, you can still find it. And you can take cells and give them imatinib or not, and then put them in mice and see if they engraft, and sure enough, no matter if you treat them with imatinib or not, they still grow. So the stem cells just kind of sit there and don't seem to be dependent on B-cerebral signaling, and that's kind of interesting. And then there's this study that looks at CD34, 38 negatives or 38 positives, and says you basically try to poison them with imatinib, and here's sort of the control, the committed progenitor cells. And you see as you give them imatinib, a bunch of these cells kind of move up here. These are all dying cells. This is a next label. And you get no death in these cells at all. So you would think, okay, people are being stuck on tyrosine kinases for life. Okay. Now you'd like to be able to stop therapy, if you could, right? Because some people are going to be intolerant. That's one reason to stop. That's not your best reason. Pregnancy, people might want to get pregnant, and you might want to stop therapy in people who had outstanding response. But we figured that was a pipe dream, because how could that be if you had all these CML cells around? Well, it turns out that we were actually, once again, completely wrong. That you can, in fact, there are patients who can get what we call this treatment-free remission. And one of the things I want to talk about are what are the criteria for stopping treatment, what's the definition of a molecular relapse to start retreatment, is it safe to stop treatment, and can we cure CML without something as drastic as transplant? So this is like kind of looking at the chart of how many cells and what the assays can do. So we said MMR here is a reduction to 1,000-fold. Then we get to these things called MMR4, which is 4-log reduction, 4.5-log reduction. Most PCRs can only get to about here. So we currently, the new slang for this of a 4-log reduction or more is this deep molecular response. Okay, so that's what we'll be talking about. And we don't know yet, once you get below this iceberg, how deep you have to go to get off therapy. Now, there's a variety, it's a cottage industry, these discontinuation studies now, and you have to be careful because many of them use different criteria for why you get on study, and many of them have different criteria about why you get off study. So this is looking at 4 trials, and the criteria for changing in these 3 trials is loss of MMR. This one is loss of MMR of 4.0. This one is loss of 4.5 twice in a row. So you've got all these different variations. Shockingly, as I'll show you, almost all the data looks exactly the same no matter how you cut it. This was the STOP imatinib trial, the STIM trial. This was probably the most famous. There's one Kaplan-Meier curve I'll show you. This is probably the most famous CML Kaplan-Meier curve now in the last decade. This took patients who had been on imatinib for some time, was in a complete molecular response, which means no detectable B cerebral, and you had to have that for at least 2 years, then you stop therapy. And when Francois Mahon started this, all of us sort of kind of bet that within 6 months, everyone would relapse. Right? So we were way wrong. So if you look at patients who you decide loss of response by either loss of complete molecular response or a loss of MMR, so the curves are slightly different, you find that roughly 50% of people who stop therapy are still negative after 2 years. The ones that relapse almost all within the first 3 to 6 months. They relapse quite quickly. But shockingly, years out, people are still negative. This is the cumulative incidence of going back into a response once you failed. So far, almost all the patients have gone back to response. There's only been a few outliers. Now, they all don't become negative again, and we'll talk about the implications of that later. But most go back in response, and it takes a while. On this trial, there was one person who went into lymphoid blast crisis afterwards. We have a patient locally who decided to get pregnant off study. She became pregnant, and then just before she delivered, she developed lymphoid blast crisis in her brain. So that was a bad outcome. So this is not without possible consequence. This is the Twister study from New Zealand, and the same theme, 40% out to 6 years off therapy. This is going to get boring because it's going to be the same thing after this trial. This is the second generation trial after in France. So that here, as opposed to the first STIM trial where it was all imatinib, these are people who are all on second generation drugs, either as first therapy, or a few of them are actually people who started on imatinib and got switched. And they basically, it's the same criteria. You have to be a great response for at least 2 years, and you have to be on therapy for at least 3 years. If I can turn that. That's this curve. And the theme is 40 to 50%. It's going to be kind of boring after a while. This is the Euroski study, which I think is a great acronym for the Norwegian study. This is essentially the same kind of criteria. They now have done, this is kind of remarkable, they've actually now enrolled 600 patients on this trial. And they did an interim analysis of the first 200 where they had enough follow-up on, and that's the curve, 50%. So remarkably, there's the core group of people that are going to stay off therapy for a while. And if you look at these patients, most of them relapsed within 6 months. Of the 89 who lost MMR, 76 regained MMR, some deeper. 15 lost complete cytogenetic remission, but then regained MMR. So total, only 8% have not got down to an MR4. So that's the cost, is whether these people are going to go on and do anything outlandish like progress. Now there is, as you might expect, if this is all a matter of like whittling away the stem cell pool, there's an effect of the time of duration of therapy. So if you look at, in the European Leukemia Net, patients who have had less than 8 years of therapy or greater than 8 years of therapy at the time of discontinuation, your relapse rate's higher in those with less therapy. Right? That makes some sense. If you're whittling away the stem cell pool, the longer it is, the better. And then if you look at patients who had at least an MMR4 and how long they had that response. So there's an interaction here between how long you're on therapy and how long you've got the deep response. So if you've got an MMR response of at least 5 years or greater, that's your relapse risk. And if you haven't had that response for as long, it's higher. So I think all of that makes some intuitive sense. This just looks then at just looking at one point of time in this study about what level are you at when you discontinue. So not taking time of duration, because again, the time of duration and the depth are sort of interactive, and it's kind of difficult to ferret out. But it looks like 4 versus 4.5 may be a little bit different. Probably it doesn't make any difference how deeper you are there. So there's probably going to be some critical level of definition of log, but right now most of the trials are happy to enroll people with that response or with that response. Now, there are some adverse events. Curiously enough, some patients will have this reactive musculoskeletal pain, joint pain, arthralgias. In a lot of patients, it's pretty severe. It usually happens in the first couple months. And we're not sure what this is due to, but we are thinking that maybe these drugs often affect KIT. And we think that maybe somehow uncovering KIT activity is causing this to get through. Most people can get through this if you basically treat them symptomatically enough. Yeah, but at first, a few of them clamor to get back on the drug. But there is a trial now in the US that started. This is the great acronym, Life After Stopping Tyrosine, the last study. And it is basically a trial where we don't care what drug you're on before you get here. A lot of the pharma-based ones want you to be on nilotinib and always nilotinib, or imatinib and then nilotinib. We don't care what you got as long as you have a deep enough response. So nilotinib, imatinib, dasatinib, badger meat, whatever got you there is good, and then we're going to take you off. And so we're basically looking at these patients. They've got to have a response, and we've actually enrolled quite good. Well, now we're probably about 100 patients. These are all the places that you can get patients into. So if there's any of these centers near you, we're happy to get your enrollment. So conclusions: about 40% of patients with stable CMR will have a prolonged remission. The rate's about 60% if you just use the rate of MMR as the criteria as opposed to just falling out of this. We still think that discontinuation should only be done in a clinical trial because there is a cost, and we'll talk about the potential cost in a moment. Now, the cost is that these diseases can have a rather spectacularly long latency. This is kind of a schematic of the CML after the Hiroshima and Nagasaki bombs. Surprisingly, there's a remarkable study cohort in the bomb survivors. Some of them are still around because there's a large amount of patients people who had the remarkable foresight to be out of town during this interval of time when the bombs fell. When they migrated back, they were watched scrupulously, and so they became a perfect control group. So one of the interesting things is that this is the percent increase over the baseline of risk of CML. 5 to 15 years after, 16 to 35, up to 55%. They still see an increase in CML in the blast survivors. They also see an increase in AML, which suggests that some of these diseases can have a remarkably long latency period of time. And in the discontinuation trials, if you think that CML has multiple clones and you now have unopposed BCR-ABL signaling for 3 months, 6 months, 9 months, you put them back, they relapse, you put them back on therapy, you may attack most and kill most of the clones that are contributing to that relapse. But if there's a clone in there who has now had sort of the genetic bedlam and has progressed on the load to accelerated phase of blast crisis, you may not see that manifest in these trials for 5 or 10 years. So we are not sure that all the patients that we've discontinued, they respond to therapy, we're not sure that those people haven't in some way been harmed and that they may all start relapsing 10 years out or so. I kind of doubt it, but theoretically from a biology standpoint, that's certainly a possibility. So one of the things we'd like to do is, since there is this potential risk, is it'd obviously be very nice if we could actually look at patients who are in CMR or a good response and say, well, are you going to relapse or not, right? And so the lowest hanging fruit in that is that if you just develop a more sensitive assay, right? So the idea there is, all right, the ones that relapse are the ones that actually have more disease, and if you had a better assay, you pick those up, right? So how do you do that? How do you get a more sensitive assay? And one idea is the so-called digital PCR. So the idea of digital PCR is instead of doing one PCR and determining your BCR-ABL, you basically do tens of thousands of PCRs simultaneously, and you just call them positive or negative, and then back calculate the percentage of cells by a Poisson distribution. And you can do this in two ways. The Fluidigm system uses single molecules in wells. These are all tubes and wells. They actually fall upon each other, so as they inflate one tube, it seals the other one. And so they can actually distribute fluid about 10 picoliters, which is about a billionth of a liter. You can't see it. you can actually distribute PCR reactions to 10,000 wells simultaneously, right? So that's pretty nifty. And do quantitative PCR 10,000 times. The other way is basically partitioning RNA into droplets. You basically take your cells, you lyse them, you take the RNA, you dilute it to the point that if you actually insert them into a myocell, essentially a soap bubble, there'll be less statistically than one copy per bubble. Then you actually, these bubbles have the PCR reagents. You do the PCR, run them over a laser, and again, they calculate them as yes or no. This actually works, surprisingly enough. This is looking at a Poisson distribution on the fluidized system as predicted versus as calculated from the PCR reads over 10,000 wells, and it's pretty good. And this is for people who are history buffs. This is the first use of the Poisson distribution in a book called The Law of Small Numbers. And how it was calculated is the first use of the Poisson distribution was to calculate the number of deaths by horse kicks in Prussian military officers. And they found that over the years, it fit a Poisson distribution perfectly. So if you're ever on a game show and they ask you where the original Poisson distribution is, and you win, as you should now, I expect a kickback. And this is how it works. So this is a patient where the PCR didn't come positive here, a regular PCR, but by this digital PCR, you could pick up copies and all of these things 6 months prior. So there is something to it. And this has been now looked at in a series of patients who were PCR negative. So this is a fluidime assay. And they found they were basically the patients, this is your risk of not relapsing, so that's the best, this is the worst. And for reasons that aren't clear, the best group is those patients who are older and are digital negative, right? The digital negative makes some sense. I don't know why the older would make any sense. And the worst group are the people who are young and are PCR positive. So this is probably the only advantage I know of being my age. Is that if I ever kept, so the wisdom thing is completely overblown, believe me. But there may be something to it besides just copy number. I think we're assuming that. And now, and in various labs, my own and some others, it looks like there might be an immunological effect to some of this. So the immunology might ride herd on some of this thing. Because we know immunology is very affected in how CMLs behave, interferon, transplant, and the like. And this is just in a diagram, but there's a lot to immunology that we don't understand. Okay, so this is looking at gene expression arrays. So those who are not red or who are red or green colorblind, I apologize. So what this is doing is it's taking normal people. Well, they're not actually normal. They worked in a lab. But you normal people, and you take their peripheral blood, and about every few weeks to months, you actually take the blood, and then you do gene expression arrays to see what genes are overregulated in the blood cells. And so you take, these are like 15 patients, 70, and these are about 100 samples. And so what you do then in this algorithm is you say, you don't specify which sample is which sample. You say to the mathematical algorithm, pick out the genes that separate all these samples and cluster them into signatures that look similar, and tell me what it looks like. It's called unsupervised clustering. And so what you find is that there are 72 genes out of 30,000 that distinguish all of us apart in the peripheral blood. And here's who it says these people are. It just says these guys look alike, these guys look alike, these guys look alike. And then when we looked, we said, well, that's amazing because it did that and made no errors. That's impossible. So we did it again on another group of people, and we found the same thing. 72 genes, no errors. Now, why that was really interesting is that many of these are inflammatory and immune-regulated genes. These guys here are all interferon response genes. And in both groups, we found that 20% of genes had high activated interference response genes. When you took lymphocytes from those people and squirted them with interferon, they went up spectacularly. So baseline is black. This is taking these patients who had the high interferon response genes and jolting them with interferon, they go up even more. So there's a subset of people walking out there who just have interferon response genes jacked up. Right? So that's interesting because if you look at where interferon works, in CML and renal cell cancer and hepatitis C, in colon cancer, how often does it work? It works 20% of the time, which makes you think that our immune systems are priming us to responses. And maybe there's a secret sauce like this in the people who have a great molecular response that we'll be able to predict, yes, you can safely go off, your disease will be under control, versus no, you're going to relapse and it's not worth the risk. All right, so here are the last questions. Can all patients in sustained molecular relapse-free remission? Probably not. We think there are various trials now to try to drive people who don't have a complete molecular response down by adding new agents and the like. There just may be an intrinsic, some patients who are never going to get that good a response. And no matter what you do, how you beat on them, it's not going to happen. Remember, 10% of patients with an allogeneic transplant still relapse, for God's sakes. So the chance that you can cure people just with tyrosine kinases is maybe a bit of a high bridge. What molecular level is a realistic target? We don't know. What's the minimal duration of that we need pre-treatment before stopping? We don't know. Are there prognostic factors for reaching that? We don't know. And do we know, is interferon helpful? In some of the early trials, people who had gotten interferon before they had tyrosine kinases actually had a much better complete molecular response and actually stayed in remission longer. So it may well be that there's some immunological effect that lasts. And that's it. Thanks.